We will go on our program today. Our chief guests for the day are all present over here. Let me first welcome our main chief guest of the day, Sri Loknath Behera. He is a retired IPS officer, a very well-known name in Kerala. He was the state police chief and the director general of Kerala State Police and former too. He hails from one of the founders investigation agency. He was also
Dimple, I am not able to hear you.
Sir, ne onnu unmute you. Sir, you are audible. Sir, we can hear you.
Yeah. So you want me to speak?
Yes, sir.
in
I just wanted
Kerala
to
police
tell
with
one thing
modern
to
vehicles
all
and
the
state-of-the-art
attendees
small
who are
arms and non-lethal
attending, very
weapons.
important
He was also
persons,
managing
that
police medal.
you can trust Swasthi, because when I was the DGP, we did a lot of good programs relating to one for the police people suffering from cancer and kind of things. A very dedicated bunch of people. They want to actually propagate and make aware people how serious is the issue of breast cancers. I was very shocked to know, to learn from the members of the Swasthi that even younger girls are having that particular problem. It is not it is a myth that only the older people, older women will get. So it is a very serious issue. And many of the time, things which have been prescribed by various cancer societies and experts to actually early detection will be very good for treatment. We, even after educated people, also don't do that. So the other day when I was talking to few esteemed members of the Swasthi, including Abhi and Dimple and all, when that is time, and when I was talking to Karkinos, the lab, etc., they were telling that we must actually make all the people aware. The girls also should be aware of these are the very unfortunate things which happen, and it is a reality. So when Swasthi decided that they will go for a global convention and actually propagate this one, that is nothing better than that. I do not think anybody has done such a in a massive scale which Swasthi can do, because all people who are driving Swasthi are very committed. Trust me, that I have already actually experienced. I don't have to say this one because I am attending a video conferencing. It is a fact. So now what do you have to do? Tell maximum people, actually, whoever is I mean your near and dear ones or your friends, about this program, because this program will be live streamed. Am I correct, Dimple? Because most of the people can be, actually we are planning that so that it reaches maximum number of households, not only in Kerala but other parts of India and maybe outside India also. So what are the protocols, what are the procedures, what are, whether it is preventable, whether it is curable, all these will be discussed a threadbare, and there will be also opinions and reactions taken from the viewers. That's what I understand. So that on the basis of that, we will actually take a next further course of action. And I told Abhi that actually this we will do this one and institutionalize this in a way so that once it is over, it is over. That's not the question, because the problem is going to remain there. but how to actually go on continuously in actually propagating that. That is what I thought I should actually tell. And I'm sure that you all have come because you are committed and you feel passionate that it should actually, we should minimize the incident of breast cancer in the whole world. So I take actually, I stop here. In case of anything, Dimple can let me know, and I will be too actually interested to do whatever best I can do. Even I was telling that we can use the metro platform, our social media, as well as our stations, our trains, or water metro, also to propagate this particular awareness program very, very candidly and exhaustively. Thank you, Dimple.
Thank you very much, sir, for vouching for Swasthi and for showing your support to us and for the message to all the people.
Yeah. So
I would
you just keep a track of everything. Tomorrow morning, give me a little weekend because I have some people at home. I thought that because I didn't realize that it is a Sunday. So that is fine. But you let me know whatever from my side it's to be done. I will certainly do it. I will
sure,
take
sir.
on and I will come and see you in Trivandrum very shortly.
Sure, sir. We will get back to you. Thank you, sir.
Thank you. Thank you.
Thank you,
Thank
sir.
you.
Our next chief guest for the day is Srimati Rachana Narayankutty. She is a well-known personality, an actress, a Kuchipudi dancer, and a television star presenter. She was born in Thrissur to Narayankutty and Narayani. She graduated from Sri Vyasa NSS College and worked as a communicative English teacher in Thrissur. She was an avid dancer before her foray into the television. She started her film career in 2001 and also had a strut in as an RJ in Radio Mango. Welcome to you, Ms. Rachana Narayankutty, and over to you.
Namaskaram everyone. I'm so happy to meet you all here in this beautiful platform. You want me to talk in English or Malayalam?
I think you can do Manglish also.
Okay, fine. Pretty good. Okay. എല്ലാവർക്കും നിറഞ്ഞ സ്നേഹം. സത്യം പറയാച്ചാൽ ഞാൻ ഇന്ന് എനിക്ക് ജോയിൻ ചെയ്യാൻ പറ്റുമെന്ന് വിചാരിച്ചില്ല. ഞാൻ ഇന്നലെയാണ് ജോയിൻ ചെയ്യണ്ടേ എന്നാണ് വിചാരിച്ചിരുന്നത്. ഇന്നിപ്പോ ആക്ച്വലി എൻ്റെ ഒരു PhD ക്ലാസ് നടന്നുകൊണ്ടിരിക്കുകയാണ്. അപ്പൊ അതിന്റെ ഇടയിലാണ്. ബട്ട് I'm really happy because even October 9th ഇവിടെ തൃശ്ശൂരിൽ ഒരു ബ്രസ്റ്റ് അവയർനെസ് ക്യാൻസർ അവയർനെസ് പ്രോഗ്രാം ഉണ്ടായിരുന്നു, ബ്രസ്റ്റ് ക്യാൻസർ അവയർനെസ് പ്രോഗ്രാം. പക്ഷെ I couldn't attend that. അപ്പൊ ഞാനിങ്ങനെ ആലോചിച്ചേ ഉള്ളൂ, എനിക്കത് പറ്റിയില്ലല്ലോ. അപ്പൊ എന്താണ് സാധാരണ എനിക്ക് ഇങ്ങനത്തെ ചടങ്ങുകൾക്ക് പങ്കെടുക്കാനും അതിന്റെ ഭാഗമാവാനും വളരെ സന്തോഷമാണ്. സോ അത് പറ്റിയില്ലല്ലോ എന്ന് ആലോചിച്ചിരിക്കുമ്പോഴാണ് സരയു എന്നെ വിളിക്കുന്നതും ഇങ്ങനെ പങ്കെടുക്കാൻ പറ്റുമോ എന്ന് ചോദിക്കുന്നതും. ആൻഡ് ഓഫ് കോഴ്സ് അമ്മ ഇതിന്റെ ഒരു ഭാഗം കൂടിയാണ് എന്നുള്ളത് വലിയ 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 സന്തോഷമാണ്. അമ്മയും സ്വസ്തിയും IRIAയും ചേർന്ന് നടത്തുന്ന ഈ ഒരു അവയർനെസ് ക്യാമ്പയിൻ വളരെ ശക്തമായിട്ട് തന്നെ മുന്നോട്ട് പോകുന്നു എന്നുള്ളത് വളരെ സന്തോഷമുള്ള കാര്യമാണ്. സ്വസ്തി ഫൗണ്ടേഷനെ പറ്റിയിട്ട് ഞാൻ ഒരുപാട് കേട്ടിട്ടുണ്ട്. കാരണം മഞ്ജു ചേച്ചി എപ്പോഴും പറയാറുണ്ട്, ഞങ്ങളുടെ എല്ലാവരുടെയും സുഹൃത്തായിട്ടുള്ള മഞ്ജു ചേച്ചി എപ്പോഴും പറയാറുണ്ട്, അപ്പം ചെയ്യുന്ന സത്കർമ്മങ്ങളെല്ലാം അത്രയും ജനങ്ങൾക്ക് ഉപകാരപ്രദമാകുന്ന രീതിയിലുള്ളതാണ് എന്നറിഞ്ഞതിലും ഒരുപാട് സന്തോഷം. ഇത്തവണ ഞങ്ങൾക്ക് കൂടി, അമ്മയ്ക്ക് കൂടി അതിന്റെ ഒരു ഭാഗമാവാൻ സാധിച്ചു എന്നുള്ളത്, ജനങ്ങളിലേക്ക് കുറച്ചും കൂടി എത്തിക്കാൻ സാധിക്കുന്നു എന്നുള്ളത് വലിയൊരു കാര്യമായിട്ട് കരുതുകയാണ് ഞാൻ. ജനറലി നമ്മൾ പറയുമല്ലോ, അവയർനെസ് ഇസ് ദ വെരി ഫസ്റ്റ് സ്റ്റെപ്പ് ടുവേർഡ്സ് പ്രിവെൻഷൻ ആൻഡ് ഏർലി ഡിറ്റക്ഷൻ എന്നുള്ളത് പറയുമല്ലോ. അപ്പോൾ ഇത് എല്ലാവർക്കും അറിയാനൊരു സാധ്യതയാവുക എന്നുള്ളത് തന്നെയാണ് ആദ്യത്തെ പടി എന്നുള്ളത് ഞാൻ വിശ്വസിക്കുന്നു. ഒരുപാട് സന്തോഷം. ഞങ്ങൾക്കും ഇതിന്റെ ഭാഗമായിട്ട്, അമ്മയിലെ അംഗങ്ങൾക്കും ഇതിന്റെ ഭാഗമായിട്ട് 11 ജില്ലകളിലായിട്ട് ഇതിന്റെ ചെക്കപ്പും കാര്യങ്ങളും എല്ലാം ചെയ്യാനുള്ള ഒരു സൗകര്യം കൂടി ഒരുക്കി തന്നിട്ടുണ്ട് എന്നുള്ളതിൽ വലിയ സന്തോഷം. 40+ ആയിട്ടുള്ളവരെല്ലാവരും തന്നെ ഇത് ഉറപ്പായും ചെയ്തിരിക്കണം എന്നുള്ളതും ഇപ്പോഴാണ് നമ്മൾക്ക് ഇതിൻ്റെയൊക്കെ ഒരു യാഥാർത്ഥ്യം എന്താണെന്നും അതിലേക്ക് നമ്മൾ കൂടി അതിൻ്റെ ഭാഗമാവണം, നമ്മളൊരു മാതൃകയാവണം എന്നുകൂടിയും നമുക്ക് മനസ്സിലാവുന്നത്. അമ്മ എപ്പോഴും അമ്മയുടെ അംഗങ്ങളെ സപ്പോർട്ട് ചെയ്യാൻ എപ്പോഴും പ്രവർത്തിച്ചുകൊണ്ടിരിക്കുന്ന ഒരു സംഘടനയാണ്. പക്ഷെ അത് മാത്രമല്ല, ഒരു സംഘടനയ്ക്കുള്ളിൽ മാത്രം ഒതുങ്ങുന്നതല്ല, ഒരു സമൂഹത്തിനു കൂടി വേണ്ടി നമ്മളെല്ലാവരും ഒരുമിച്ച് പ്രവർത്തിക്കണം, ഒരു വേർതിരിവും ഒന്നുമില്ലാതെ ഒരുമിച്ച് പ്രവർത്തിക്കണം എന്നുള്ളതിൻ്റെ ഏറ്റവും വലിയൊരു ഉദാഹരണമാണ് ഇന്നത്തെ നമ്മുടെ ഈ ഒരു അവയർനെസ് ക്യാമ്പയിൻ എന്നുള്ളത്. ഏറെ സന്തോഷം. നമുക്കെല്ലാവർക്കും ഒരുമിക്കാം ഈ ഒരു അറിവ് പടർത്താനും ഒപ്പം പ്രതീക്ഷ പടർത്താനും എല്ലാവർക്കും ശക്തി പകരാനും അതുപോലെ ഒരു സമയോചിതമായിട്ടുള്ള ഒരു മെഡിക്കൽ ഗൈഡൻസ് ലഭിക്കാനും എല്ലാമായിട്ട് നമുക്ക് എല്ലാവർക്കും ഒരുമിച്ച് പ്രവർത്തിക്കാം എന്ന് ആത്മാർത്ഥമായിട്ട് വിശ്വസിക്കുന്നു. ഒപ്പം തന്നെ ലെറ്റ്സ് പ്ലെഡ്ജ് to support every fighter, and let's honor every survivor and remember every life who was touched by this journey. എന്നുള്ളതാണ് എനിക്ക് ഈ അവസരത്തിൽ പറയാനുള്ളത്. എന്താവശ്യമുണ്ടെങ്കിലും എപ്പോഴും ഒരു ഫോൺ കോളിൽ ഞങ്ങൾ എല്ലാവരും ഒപ്പമുണ്ട് എന്നുള്ളതാണ് ഞങ്ങളെ കൊണ്ട് ചെയ്യാൻ പറ്റുന്നത്. ഞങ്ങളെല്ലാവരും കലാകാരന്മാരാണ്. അപ്പം പക്ഷെ ഞങ്ങൾക്ക് കുറെ പേരെ ഇൻഫ്ലുവൻസ് ചെയ്യാൻ സാധിക്കും എന്നുള്ളത് വലിയൊരു സത്യമാണ്. അത് ഒരു അനുഗ്രഹം കൂടിയാണ്. ഡോക്ടേഴ്സിനെ പോലെ തന്നെ ഒരുപാട് പേർക്ക് ഞങ്ങളിൽ പ്രതീക്ഷയുണ്ട് എന്നുള്ളത് വലിയൊരു അഭിമാനം കൂടിയാണ്. അതുകൊണ്ട് എന്ത് തന്നെ ഉണ്ടെങ്കിലും ഞങ്ങൾ കൂടെ ഉണ്ടാവും എന്നുള്ള ഒരു ഉറച്ച വിശ്വാസം നമുക്കെല്ലാവർക്കും ഒരുമിച്ച് പ്രവർത്തിക്കാം. ആൻഡ് താങ്ക് യു സോ മച്ച് ഫോർ ദ വാം വെൽക്കം. താങ്ക് യു സോ മച്ച് ഫോർ ഹിയറിംഗ് മീ ആൻഡ് ഐ വിൽ ബി സീയിങ് യു ഓൾ സൂൺ. താങ്ക് യു. നമസ്തേ. I think ma'am is not. The network connection is on and off, I believe.
Of the Department of Surgical Oncology at Malabar Cancer Center, Thalassery. He is the chief patron of the Kerala Association of Surgical Oncologists, and he completed his degree in surgical oncology at ADA. Dr. Satheesan?
Yeah, am I audible now?
Yes, sir.
Yes,
You're
sir.
audible, sir.
Yes, sir. You're
Yeah.
audible.
Yeah. Okay. Yeah. Thank you, Swasthi, for giving me this opportunity. And as already two speakers earlier, they have very beautifully they have articulated the requirement of such an awareness program and the importance of this month. Then my job is to just giving a certain scientific inputs into it. And today we are talking about the staging of breast cancer. So the staging is a very important aspect in cancer management. See, whenever we diagnose cancer, the next step we go into is to stage the disease, at what stage it is. Generally, broadly for the people, we say that's an early stage of cancer and the late stage of cancer. So for this, we have to do certain tests, certain battery of tests, and we have to identify what extent the disease is there locally also, and whether this has gone to some regional areas or it has gone to the distant parts. So the staging is a very vital part in the management. And today we have eminent speakers they are speaking on the staging of the disease. So this will be very useful for all those who listen to this talk. And if they have any doubt, because this is something even the patients need to know how this is being staged and what are the tests to be done. And often they do have doubts on the types of tests being conducted, whether the such test for every patient should we do all the tests, or it's only for certain tests for certain type of patients. All these things will be discussed during, I'm sure it will be discussed during today's discourse. And I wish them all the best. I wish the society will take up such endeavors in future too, and it will benefit thousands and thousands of people. And the awareness is the most important aspect in preventing the disease, because more than diagnosis, we have to ensure that, and we should take some steps to prevent cancer. So definitely, the SSC has taken a very noble step, and wish SSC all the best. And thank you very much.
Thank you, Satheesan sir, for your message and for your support for the program. Next, we are going on to the talk session today. And first of all, among the speakers, the whole program, the talk is going to be chaired by Dr. Harish S. He's the Associate Professor and Head of the Department of Medical Oncology of Government Medical College, Trivandrum. And we have two speakers today, Dr. Rakul Nambiar, Consultant Medical Oncologist at Sri Gokula Medical College, who is going to be speaking on the stages of breast cancer and their treatment implications. And Dr. Jassim Koya, he is a diagnostic and interventional radiologist at Maulana Hospital, Malappuram, who is going to be talking about how radiologists worked with oncologists and surgeons. I invite Dr. Harish to chair the session.
Thank you, madam. Actually, breast cancer, as you all know, is the leading cause of cancer in females. It's actually the second, the most common cancer among in the world. 1 in 12 females are predicted to be diagnosed with breast cancer in their lifetime. So it is of utmost importance to diagnose the case at an early stage and allow screening. And you all know about Pink October. Every year we celebrate the breast cancer awareness month in the month of October. That is to increase the awareness of early diagnosis and breast cancer screening. It has been started since 1985. So for an effective treatment, that is the breast cancer definitely had a multimodality treatment approach. So for the treatment to be effective, it should be diagnosed at a very early stage. So comes the importance of staging. We have two talks today. So first talk, I will invite Dr. Rakul Nambiar, who is the medical oncologist at Sri Gokulam Medical College, to deliver his talk on the staging of breast cancer and its treatment implication. So it's over to Rakul.
Is my screen visible?
Yes.
Okay. Thanks to Swasthi team for giving me this opportunity. And my topic is stages of breast cancer and their treatment implications. As we all know, whenever a patient is being informed that the patient has breast cancer, the very first question that they ask is, what is my stage? So what exactly is cancer staging? Staging is the process of determining how far a cancer has grown and spread in the body. So what is the staging system that is used for breast cancer staging? It's the TNM staging. It is the common staging system that is used for all cancers. So what does TNM stand for? T stands for tumor, N stands for node, and M stands for metastasis. In tumor, we have T1 to T4. In node status, we have N1 to N3. And for metastasis, we have M0 and M1. So let us look at each one of them individually. Let us look at tumor status. Okay. T1 stands for any tumor that is less than or equal to 2 centimeter. Based on the size, it has been subdivided into T1A up to 5 mm, T1B 5 to 10 mm, and T1C 1 centimeter to 2 centimeter. This is T1 staging. T2 stands for any tumor that is between 2 to 5 centimeter, and T3 tumor is any tumor more than 5 centimeter. So T1, T2 and T3 is basically based on the size of the tumor. Coming to T4. T4 is slightly different. It's based on the tissues that is involved. T4A stands for tumor that is involved the chest wall. T4B stands for tumor that is involved the skin. T4C is basically T4A plus T4B. T4D stands for inflammatory breast cancer. This completes the T status, that is the tumor status. Now let us look at N status. N status, coming to N1. N1 is involvement of the axillary nodes which are not fixed or matted. This is N1 status. N2 is N2A, which is fixed or matted nodal mass of the axillary nodes, and N2B is presence of internal mammary nodes. Coming to N3. N3A is involvement of the infraclavicular group of lymph nodes. N3B is involvement of the axillary and the internal mammary nodes. N3C stands for involvement of the supraclavicular node. So far, we have looked into the clinical nodal status. There's something known as the pathological nodal status. This is slightly different. This pathological nodal status is obtained after the patient has undergone surgery. The main difference between the clinical nodal status and the pathological nodal status is that pathological nodal status also gives importance to the number of lymph nodes that is involved. PN1 is involvement of up to 1 to 3 axillary lymph nodes. PN2 is involvement of 4 to 9 lymph nodes, and PN3 stands for involvement of 10 or more lymph nodes. So the main difference between clinical and pathological nodal status is that PN status also gives importance to the number of lymph nodes that is involved. So far we have looked into the T staging and N staging. So let us come to the M staging, that is the metastatic workup of the patient. We can, for staging purpose, we do a CECT chest, abdomen and pelvis plus the bone scan, or we can get it done as CT scan. This is the staging imaging evaluation that is done for cancer patients. So once we have the T, N and M status, we can determine the final stage of the patient. And that is stage 0, which is basically non-invasive tumor. That is carcinoma in situ is stage 0. Stage 4 is when the patient has a metastasis. That is basically any M1 stands as stage 4. For stage 1, it's basically any tumor which is less than or equal to 2 centimeters. So stage 0 is non-invasive. Stage 1 is up to 2 centimeter without nodal involvement. And stage 4 is metastatic disease. So basically anything in between is stage 2 or stage 3. So this is the final stage of a breast cancer patient. Based on this T, N and M status, we give the final stage of breast cancer patient. And so we have attained the final stage of the patient. So let us look how the staging determines or the treatment implications of breast cancer staging. How does staging affect the treatment of the patient? Staging can determine the treatment intent, can determine the treatment duration, the treatment modalities that is used, the cost of treatment, and it also determines the follow-up of breast cancer patient. How does treatment intent is being determined by the stage? For an early breast cancer, the main intent of treatment is cure. And so the treatment pathway is when an early breast cancer patient presents to the OPD, the patient will be first taken up for surgery, followed by adjuvant chemotherapy or radiation. This is the usual pathway for early breast cancer patient, and the intent of treatment is cure. For locally advanced breast cancer, the first thing to be done is downsizing the tumor and then go for a cure. So for a locally advanced breast cancer, the first treatment is going to be a systemic therapy, which is chemotherapy, by which we will be able to downsize the tumor and then take up the patient for surgery, followed by radiation. So for early and locally advanced breast cancer, the intent is cure. Now coming to metastatic stage 4 disease. Here, the intent is slightly different. We all know that stage 4 disease cannot be cured. It can only be controlled. So here, the intent of treatment is symptom control. And the main treatment modality that is employed for stage 4 disease is systemic therapy, which is chemotherapy or targeted therapy. Radiation therapy and surgery are usually plays a very minimal role in the treatment of stage 4 cancer. So intent of treatment is determined by the stage of the patient. It's curative for early and locally advanced, whereas for metastatic, it is going to be palliative or symptom control. Coming to the treatment duration, for early and locally advanced breast cancer, the treatment is for a finite duration, meaning it usually ranges from 6 to 12 months. Whereas for a metastatic disease, as we already know, it's basically symptom control. So there is no finite duration. It's a continuous process. It continues till the death of the patient. So basically for metastatic disease, the treatment is a continuous process. Coming to treatment toxicity, as previously mentioned, the main intent of treatment for metastatic breast cancer patient is symptom control. So the treatment with the least toxicity will be preferred for stage 4 cancer patients. Whereas for early and locally advanced, our main intent is cure. So some amount of toxicity is acceptable for early and locally advanced. Whereas for metastatic disease, the treatment with the least toxicity should always be preferred because our intent is palliation or symptom control for stage 4 breast cancer. So treatment toxicity should also be included in the treatment management of breast cancer patient. Coming to the cost, the treatment for early and local, the cost of treatment for early and locally advanced breast cancer is finite because we know that the treatment is going to end within 6 or 12 months. Whereas for stage 4 disease, as it's a chronic process, we cannot be sure how much cost it will take. It's going to be a continuous process and multiple modalities of treatment will be required. So the treatment is going to be highly expensive for metastatic and stage 4 breast cancer patient. As previously mentioned, surgery and radiation plays minimal role in stage 4 treatment. Surgery as well as radiation is mainly for symptom control. Surgery is used as palliative toilet mastectomy for stage 4 disease, and radiation can be used for symptom control like bone pain or brain metastasis. So surgery and radiation plays a significant role in early and locally advanced, whereas for metastatic disease, surgery and radiation has comparatively lesser role compared to systemic therapy. So summarizing the treatment implications of staging, the intent is going to be curative for early breast cancer. It's downsizing and curative in locally advanced, and it's palliative for metastatic disease. The treatment duration is finite for early and locally advanced at 6 to 12 months, whereas it's a continuous process for metastatic disease. The cost is going to be highest for the metastatic disease. And toxicity, the treatment with the least toxicity should be preferred for metastatic disease. And modality, surgery, chemo, and radiation all play a role in the treatment of early and locally advanced, whereas for metastatic, it's going to be systemic treatment plays the major role for metastatic disease. Follow-up. Follow-up is protocolized and intensive for early and locally advanced, whereas metastatic, it's based on the symptoms. We don't have a finite or protocol-based follow-up for metastatic disease. The follow-up is mainly based on the symptoms of the patient. Thank you. That was about staging and the treatment implications of staging for breast cancer.
Okay, thank you, Rakul. And as it was an excellent presentation. Is concisely you have explained the staging of the breast cancer. Even though for this wide audience, it may be little difficult to understand. But in our, I do want to add that there is a lot more than what we have been presented because with the new biomarkers and all, the staging is very complex for the oncologist. And one more thing to add, the early breast cancer is totally curable. And even though he told that stage 4 disease, the treatment is indefinite and time consuming, but definitely it is rewarding because with the new molecules, the survival has increased leaps and bounds. So there is not at all a worry to have because you know that the hormonal status is a crucial role even in stage 4 disease. So thank you, Rakul. Now, now the next talk we will be having is from the radiological aspects, how the radiologists work with the oncology and surgeon. It should be presented by Mr. Dr. Jassim Koya. He is the consultant diagnostic and intervention radiologist at Maulana Hospital. So I invite Dr. Jassim Koya to present the presentation.
Thank you, Dr. Harish, sir. First of all, from the outset, I'd like to thank the organizers of this program IRIA Kerala, the Swasthi Foundation, and AMMA for having me here today. I'll be discussing. Can you see my slide, sir? Is the first slide visible?
Yes, yes.
Okay, so I can go on. Thank you for having me. So at the outset, I'd like to say, I just want to convey in the next few slides about how a radiologist has something to do with the treatment and the detection, treatment, and the management of breast lesions. So what are the radiologist's role? To sum up in just one slide, it is one, imaging characterization. Once you detect a lump, the imaging is done usually in a mammography or a sonomammography. And with that, we characterize the lesion from least chance of having a malignancy to a highest chance of having a malignancy. So in what is called the BIRAD scoring. I'll come to that in a bit. There's also the role of image-guided biopsies, and I'll tell you why that is more better than a blind biopsy. There are also image-guided therapies that can be done, particularly vacuum-assisted excision or a VAE. And of course, they also have a role to play in the post-treatment follow-up. So what is BIRAD? So in 1980s, once mammography started coming into the foyer, what was noted was that the terms which the radiologists were using were quite heterogeneous. So it was not very uniform. And because of that, that left a lot of ambiguity and the terminology were quite confusing for the surgeons to interpret and or the oncologist and to find out what was relevant and what was not. So in 1993, they first came up with the BIRADS lexicon, and these were the subsequent refinements. I think I can skip this slide, but basically, you categorize the mammography into different categories of breast composition. That is the how much of the fatty tissue is there and how much of the glandular tissue is there. The basic endpoint being that you have to say that if it is a densely glandular breast, how much of it is going to mask a potential lesion. So because of that, we characterized it into less than 25% of the breast is glandular. Let me just try to add the laser pointer. Give me a second, please. Yeah. So that less than 25%, 25 to 50%, more than 50%, and much of the breast, almost 100%. So based on that, we characterize them into BIRADS 1 through 6. So 1 being completely normal, there are no focal lesions. And you can see that in this, there are no focal lesions. And then these patients, they don't have to undergo any procedure, or you just have to go on with a subsequent follow-up as a normal patient would, yeah, based on their age and so on. What about this? On an ultrasound, it's a pure cyst. Once you have ascertained that it's a pure cyst and there are no solid components and so on and so forth, or you have seen that in an ultrasound it is a typical fibroadenoma, it is nothing else. There are no areas of increased vascularity, there are no microcalcific foci, margins are very smooth and regular and so on and so forth. If it's that is what's called a BIRADS 2. So in these cases also, you just have to do a regular follow-up as is usually done. Nothing specifically to be done for this BIRADS 2 either. But this is a BIRADS 5. It's a very typical features of malignancy. There is a spiculated margins, this sunburst appearance, dense focal lesion. In such cases, these are BIRADS 5 lesions. They are very typical. They are almost always, they turn out to be histologically a malignancy. So the confusion happens in the stages in between. That is between in BIRADS 3 through BIRADS 4. And suppose you have this lesion here. The margins are fairly well defined, but what look like small, amorphous sort of or speckled calcific foci are there. So this is a BIRADS 3 lesion. Ideally, this requires a short interval follow-up of about 6 months, and subsequently we see if there is any increase in size of the lesion. So even a size increase of say 0.5 centimeters will be relevant because the volumetric increase will be much more. So this patient was followed up, and once this patient is followed up, we can see that in 6 months or 12 months, there's absolutely no change in the size of the lesion. So then you can subsequently downgrade after 2 years. If this lesion has not increased in size or has not changed in morphology over this period of 2 years, you can downgrade it to BIRADS 2. and you can just leave it as such. No biopsy or tissue sampling or nothing has to be done for this patient. Whereas this is another BIRADS 3 lesion. We can see this small calcific foci. Just ask the patient to come for follow-up, and in a 1-year follow-up, you can see that these foci of calcifications have increased. This turned out to be a ductal carcinoma in situ on biopsy. So that is the relevance of having a biopsy or a follow-up for a BIRADS 3 lesion. Imaging follow-up would do. Histological follow-up can be done, but that is on a case-by-case basis. So this is a BIRADS 4 lesion. Like I said, that BIRADS 5 is very typical of malignancy. BIRADS 4 is stopping short of that. It is not showing typical imaging features of benignity, but can you call it a frank malignancy? No, you can't call it a frank malignancy either. So this is a typical BIRADS 4 lesion. In BIRADS 4 also, there are subcategories of BIRADS 4 which came into being in much recently. So we have typical benign features of calcific foci. And there are also malignancy or suspicious morphology of calcific foci. And based on these features, along with the margins of the lesion and its appearance on various projections, we have sort of subdivided this BIRADS 4 into further different. The problem being that if it's a BIRADS 4, you just call it a BIRADS 4 lesion. It's about 6% risk of malignancy to 95% risk of malignancy. So this is a huge, it's a very heterogeneous group. Though you call it a BIRADS 4, it's a single number. There is a significant difference of a BIRADS 4A versus a BIRADS 4C, which is much more closer to being a malignancy. So the incidence of a tissue sample of a BIRADS 4C lesion being malignant is much more than a 4A lesion, which is only having mild features of malignancy or 1 or 2 features of malignancy, let's say. So basically what we have to look at is the pattern of calcification in the appearance, morphology. So this was why it is subdivided. The 4 was further subdivided into 4A, B, and C. So some of the tips for radiologists is that it's always better to err upward. Like it is better to call a lesion 4A and do maybe histological sampling than to miss an early malignancy. And never assign a BIRADS 5 until the morphology is truly classical for carcinoma. Compare with prior studies. As I said, anything more than 2 years is stable, has to be downgraded. And always correlate with mammography and ultrasound. So if you have a BIRADS mammography score of say 5 or 4, and if you have an ultrasound score of say 2 or 3, in that case also, if the margins look fairly normal on an ultrasound, but on the mammogram it looks much more speculated and so on, the higher grade is assigned. And once you have a regular practice of visualizing, doing studies on mammography and ultrasound, these have to be audited. The histology has to be assessed, and it has to follow within the pattern. Otherwise, you have to introspect and find out where you're going wrong. Now, these are other things that the radiologist can do, especially an interventional radiologist. So not all biopsies are created equal. Let me just remove this. Give me a second. Okay, the video isn't playing. I'm sorry about that. Just give me a second. Okay, you can see here that this lesion is a small one, and though it is a small one, it is significantly vascular. So you can see that I've gone in between the blood vessels. That you can see these vessels are also showing an arterial waveform. That means even if they are small, if you hit them, they can cause a pseudoaneurysm or a potential bleed. So I went through the vessels in a part of the lesion which is not showing Doppler waveform, and the biopsy was taken. So though here you can see that this removing of the lesion, removing of the needle is also a video capture is taken so that you are sure that you have gone through the lesion. And these are the samples which were taken. So it's a very small lesion. It's a subcentimetric lesion. Nonetheless, the margins are irregular and significantly vascular. This turned out to be malignancy. This was a young girl also. Since it's a very superficial lesion, she was able to palpate it. And this is another example where a blind biopsy was done and it turned out to be negative. There was only necrosis in that case, but an MR mammography was highly suggestive of a malignancy. So the region of maximum contrast enhancement was noted, and that region was targeted on a CT guided biopsy. And subsequently, these sections were taken, and subsequently, this turned out to be a malignancy. So you can see that this, it's not very evident in this, but the tissue which is taken is sedimenting. So once it falls down, you're sure that it's not just fat. And once it's not just fat, it's very likely that you will get a histological sample. How about this? These are PET CT scans, and here you can see these darker regions within the larger lesion. And these are the regions of increased PET avidity. So if you look at this CT scan, which is a fusion image, a CT with a PET, you can see this region is showing more of a uptake. And this is the area that you have to target for getting maximum. It's very sad for a patient to undergo multiple procedures. They undergo one biopsy procedure and they're still, where they have to wait for a couple of days before getting the report. And then you have to tell them to undergo another biopsy, which is very taxing for the patient and for the doctor. So, but if you look at these are the images I wanted to show, that not all the entire lesion shows uniform PET avidity. And those areas which are showing much more PET avidity can be targeted. This is another case, like Sir had rightly, Dr. Rakul Sir had pointed out about a locally advanced CA, which can undergo systemic chemotherapy, downstaging, and then subsequent surgery. In such cases, a radiologist can help out by placing what's called a fiducial marker. So you can see in the center of the lesion, a marker is being placed. It's nothing but a small coiled up structure. And here you can see this is the marker which is placed dead center of the lesion. And in fact, after this patient had undergone chemotherapy, none of the lesion was seen, and only the marker was visualized on ultrasound as well as mammography. So that's the blessing of having this fiducial marker in place before starting chemotherapy. Preoperatively, also for the surgeon, we can assist him in placing these markers. These are nothing but Liga clips. We stack these Liga clips along the surface of the lesion so that some of the Liga clip sticks out, so that the surgeon is able to visualize it. So here you can see this is the lesion. I'm sorry. You can see the lesion and you can see these Liga clips which are sticking out from the lesion. So half of it is inside the lesion and half of it is sticking out. Generally, I make it a point to draw a diagram also so the surgeon knows what to look for when he opens up the breast. And especially for a deep-seated lesion, this can be of particular use. Sorry. So what about treatment? Does a radiologist have a role in a treatment? So about a year back, we had the honor of doing what's called a VAB, vacuum assisted excision, which was the first one which was done in an entire complete excision. I am told that this was the first one done in Kerala. Nonetheless, this was the first one done in North Kerala, definitely. So these are the steps. And here you can see this is what's called a vacuum assisted excision. This is being sucked into this device, and we take sections and you can see the lesion getting smaller and smaller subsequently. And after that, we can see that the entire lesion is removed by doing this procedure. This turned out to be a regular fibroadenoma. Sorry. Okay. And yeah, so sometimes we can couple this vacuum assisted excision. This is a lesion, which was a 4A lesion. And after that, after doing a vacuum assisted excision, we placed a fiducial marker. This can be of particular use because I had two sisters who had come in with 4A lesions. One turned out to be malignancy, one turned out to be benign. So this is of particular use. Placing a fiducial marker is very important. Once you are doing a vacuum assisted excision for a lesion which is up to 4A. 4B onwards, generally we do not advise doing a vacuum assisted excision first. It's primarily a surgical case. So is it all smooth sailing? No, it's not. Sometimes we can get a pseudoaneurysm like this. This is not our case, but it was taken from the literature. But we have had one case in which we had to go in through the IMA and do but this is again, this is an embolization, a glue embolization where the vessel is excluded. We had a similar case, unfortunately, but it still falls within the normal expected range of, complications which can be seen during surgery. This is another interesting case which came to me last week. This was a gynecomastia, unilateral gynecomastia. He was a young gentleman. He didn't want to take tamoxifen. And so we had this excised with a vacuum assisted excision. And of course, for the treatment follow-up, as Dr. Rakul will agree, and Dr. Harish as well will agree, that much of it has to do with a lot of imaging, be it PET-CT, be it MR mammogram, or so on and so forth. So we do help along in doing an imaging follow-up as well. So thank you all for a patient hearing.
Thank you, Mr. Dr. Jassim, for an excellent presentation. Actually, as you all know, that the radiologists play a crucial role in the treatment of breast cancer, right from screening, even diagnosis, and now today I also came to know that he has also started in treatment aspect as well, as with the vacuum assisted excision. It's actually really a novel technique. So, and many times the diagnosis is straightforward in breast cancer due to the clinically we can diagnose the cancers, but many times it becomes so complex for some inoculant occult looking lesions, for which we need a very experienced radiologist. And many times we may need to have a follow-up mammograms every month. Means in the very frequently, so that to diagnose there's a borderline lesions. So thank you, Dr. Jas.
Thank you.
And now over to Madam for the further.
I would like to invite any queries or any questions towards the topics of the two speakers. Dr. Jassim, since we would be having a lot of lay persons who would be listening to this from the general population who are not doctors or in the medical field, could you say in one or two sentences on how our radiology helps both in the diagnosis as well as the treatment, along with our oncologists and the surgeons, in simple words, please?
Sure. So, firstly, the first step of detection, I believe, is not done by the radiologist or anyone else. It is done by the patient herself. So, a simple, self-examination can sometimes be the first step in identification of a lesion, especially in a younger patient. If it's above 40, the patient has willingly, underwent a mammography or a screening tool, then that's a different thing. But for a patient who probably is not a high risk patient, and like it was rightly pointed out, now we are able to see it in a younger population also, whatever be the reason. So doing a self examination is very important. I think that is the first step before anyone comes into the picture, be it the surgeon, the gynecologist, the radiologist, or anyone else. So that is the first step. And as was rightly pointed out in a couple of talks back, that once any patient is able to examine some sort of abnormality, always get it checked. There's no harm in finding, like in what happens many a times is they are hesitant to come forward to to get it tested. They're like maybe someone will be able to they're a little hesitant in getting examined. But coming forward and getting examined, because it makes a huge difference to the outcome of the patient, being detected early versus late. So that is what I want to stress, number one. And once the patient has come to the radiologist has to assure that this is a very small test that we are doing. And many people, they generally have the fear of undergoing a mammography. At the end of the day, ഇതും റേഡിയേഷൻ അല്ലേ? അപ്പോൾ റേഡിയേഷൻ അടിച്ചിട്ട് ആവശ്യമില്ലാതെ ഞാനൊരു റേഡിയേഷൻ ഉള്ള ഒരു സ്കാൻ ചെയ്തിട്ട് എനിക്ക് ക്യാൻസർ വരുമോ എന്നുള്ള ഒരു പേടി. അപ്പോൾ that has to be, first of all, you have to tell them that is not the case. കാരണം നമ്മൾ ടോട്ടൽ നമ്പർ ഓഫ് സ്കാൻസ് എടുത്തു നോക്കിക്കഴിഞ്ഞാൽ, the total, if you do take ഇയർലി നമ്മൾ അസസ് ചെയ്താൽ പോലും, like after 40 years, every year, even if you undergo an assessment, the incidence of malignancy happening is about 1 in 1 lakh women being sampled. 1 lakh scans alla, 1 lakh women sample ചെയ്ത് കഴിഞ്ഞാൽ എല്ലാ വർഷവും, I'm not talking about 2 yearly follow-up, yearly follow-up ചെയ്താൽ പോലും 1 lakhil 1 lady may have a cancer. It's a calculated risk. It's just like crossing the road. We don't know if a very fast car will come and hit us. And most of us at least have taken COVID vaccine. It is there are risks, documented risks of doing COVID vaccine. But that's what I want to highlight as a radiologist, that undergoing mammography, phobia, that undergoing a radiation-based test, that has to be removed from the general population. Then the risks are much less compared to the benefits. And after that, we do the ultrasound and so on. ഒരു ലീഷനെ ക്യാരക്ടറൈസ് ചെയ്ത് കഴിഞ്ഞാൽ then you have to do the next steps. Majority of the lesions ഒന്നും ചെയ്യേണ്ട ആവശ്യമില്ല. You just have to do a follow up. ഇനി എന്തെങ്കിലും അബ്നോർമാലിറ്റി കണ്ടു കഴിഞ്ഞാൽ ഇമേജ് ഗൈഡഡ് ആയിട്ട് ബയോപ്സി ചെയ്യുന്ന അല്ലെങ്കിൽ FNAC ചെയ്യുന്നതാണ് ഓൾവേസ് ബെറ്റർ. കാരണം the chances of undergoing a repeat procedure is much less. അപ്പോൾ always I would suggest doing it by a radiologist rather than a pathologist, because നമ്മൾ ബ്ലൈൻഡ് ആയിട്ടല്ല സാമ്പിളിങ് ചെയ്യുന്നത്. We do it under guidance. അപ്പോൾ എക്സാക്ട്ലി എവിടെ നിന്നാണോ എടുക്കേണ്ടത് അവിടെ നിന്നാണ് നമ്മൾ സാമ്പിളിങ് ചെയ്യുന്നത്. Then further beyond that നമുക്ക് പിന്നെ അത് ചെയ്ത് കഴിഞ്ഞിട്ടാണ് നെക്സ്റ്റ് സ്റ്റെപ്സ് ഓഫ് ട്രീറ്റ്മെന്റ് വരുന്നത്.
താങ്ക് യു ഡോക്ടർ. താങ്ക് യു ഡോക്ടർ. അത് കേട്ടപ്പോഴത്തേക്ക് കുറച്ച് ആൾക്കാർക്കെങ്കിലും ഈ റേഡിയോളജിസ്റ്റ് ചെയ്യുന്ന കാര്യങ്ങൾ മനസ്സിലായി കാണും. പ്ലസ് നമ്മൾ എന്തുകൊണ്ടാണ് നേരത്തെ ടെസ്റ്റ് ചെയ്യണം അല്ലെങ്കിൽ റെഗുലർ ആയിട്ട് ഒരു മാമോഗ്രാം ചെയ്യണം എന്നൊക്കെ പറയുന്നതിന്റെ ഇമ്പോർട്ടൻസ് നിങ്ങൾക്ക് എല്ലാവർക്കും മനസ്സിലായി കാണുമെന്ന് വിചാരിക്കുന്നു. ഡോക്ടർ രാകുൽ, ഒരു കാര്യം കൂടെ ഐ ജസ്റ്റ് വോണ്ട് ടു ആസ്ക്. അതായത് നമ്മൾ ഒരു ഗ്രേഡിംഗ് അല്ലെങ്കിൽ ഒരു സ്റ്റേജിങ് ഒക്കെ പറഞ്ഞു കഴിഞ്ഞതിന് ശേഷം വെൻ വി ആർ ആക്ച്വലി ഗോയിങ് ഇൻ ടു ദ സർജറി ഓർ സംതിങ്, അപ്പൊ സ്റ്റേജ് മാറി കാണാറുണ്ടോ? നമ്മൾ വിചാരിച്ചു ഈ സ്റ്റേജ് ആണ്, പക്ഷെ നമ്മൾ സർജറി ചെയ്യുമ്പം വേറൊരു സ്റ്റേജ് ആണ്, അങ്ങനെയൊക്കെ കാണാറുണ്ടോ? അങ്ങനെയാണെങ്കിൽ എന്താണ് ചെയ്യുന്നത്? Dr. Rakul? I think Dr. Rakul is not online anymore. Or okay. Any other queries by anybody? Okay, so if that is so, then we will call it a day today. And the only take-home message from the talks today and from the messages given by all is that whatever said and done, one main takeaway message is that if it is detected early, if we know what is to be done, because it is in our hands. നേരത്തെ ഡോക്ടർ പറഞ്ഞതുപോലെ ആദ്യത്തെ ആള് എന്ന് പറയുന്നത് നമ്മൾ തന്നെയാണ്. We women are the ones who have to first check it out whether we have any problems or not. എന്തെങ്കിലും abnormal ആയിട്ടുണ്ടോ, നോർമൽ അല്ലാത്ത എന്തെങ്കിലും കാണാൻ പറ്റുന്നുണ്ടോ എന്നുള്ളത് നമ്മുടെ സെൽഫ് എക്സാമിനേഷനിൽ തന്നെയാണ് മനസ്സിലാകുന്നത്. അത് കഴിഞ്ഞിട്ടാണ് നമ്മൾ ടെസ്റ്റിങ്ങിന് വേണ്ടിയോ സ്ക്രീനിങ്ങിന് വേണ്ടിയോ പോകേണ്ടത്. അപ്പം the earlier you detect, the earlier you examine yourself, the earlier you detect an abnormality, the earlier an intervention is done, ഈ ഒരു ബ്രസ്റ്റ് ക്യാൻസർ എന്ന് പറയുന്ന രോഗം കംപ്ലീറ്റ്ലി ക്യൂർ ചെയ്യാൻ പറ്റുന്നതാണ്. നേരത്തെ ഡോക്ടർ ഹരീഷ് പറഞ്ഞതുപോലെ ഈവൻ അറ്റ് ലേറ്റർ സ്റ്റേജസ് ഇപ്പൊ പുതിയ പുതിയ റിസർച്ച് ഫൈൻഡിങ്സും പുതിയ പുതിയ മെത്തേഡ്സും പുതിയ പുതിയ ഡ്രഗ്സും ഒക്കെ വന്നിരിക്കുന്നത് കൊണ്ട് നമുക്ക് ഈവൻ അറ്റ് ലേറ്റർ സ്റ്റേജസ് ക്യൂർ ചെയ്യാൻ പറ്റുന്നുണ്ട്. ഒരു നോർമൽ ലൈഫിലോട്ട് ആ സ്ത്രീക്ക് എത്താൻ പറ്റുന്നുണ്ട്. അതുകൊണ്ട് please bear this in mind that the earlier screening, the earlier detection and earlier intervention, the better chances that you will be cured of your cancer. With that message, we come to the end of today's webinar. Thank you to all the speakers, to the chair, and to all the dignitaries and the chief guests who had come for this webinar. Thank you very much all for your patient hearing.